not being interested in exercise based on the fact that drive is not my initial starting point, then I'm okay. So we need to normalize that, particularly for women as they age, that sort of craving for sex may not be the first step, but once they get started, they're okay. We want to normalize that. And so we need to differentiate what's the normal change that happens, say, with aging, and what really is low desire or hypoactive sexual desire disorder, where none of this works. Okay. Now, another model that we now think about when we're thinking about a sexual response is what we call the biopsychosocial model. Okay? It's a mouthful, but what it says is that sexuality is complicated and that there are multiple factors that contribute to women enjoying wanting to be sexual or not wanting to be sexual. And if we look at the primary factors, we think about them as being biologic, which we'll talk about, which are sort of the neurobiology. Hormones certainly affect sexual desire, testosterone in women. Neurotransmitters. Sex is in the brain. Desire is in our brain. So obviously, central nervous system factors are going to impact whether we're interested or not interested in sex. Psychologically, things about our relationships, performance anxiety. Men worry about gaining and keeping an erection. Women worry about reaching orgasm. Those are sort of things about performance anxiety. Depression. What really drives sexual interest? Not depression. Sociocultural factors. Many of you come in here with very strong religious and cultural backgrounds. All of that either supports and promotes your being healthy and happy in your sexual lives or takes away from it. So if your beliefs are, for example, that happily married people are supposed to be sexual, that's going to promote your sexual interest. If, for example, you're a 65-year-old widow who's a grandmother who believes, that doesn't believe that widows or grandmothers are supposed to be sexual, then her desire may decline based on her sociocultural factors. And finally, interpersonal factors, the quality of a relationship. You can have all the biology, right, all the biologic urge in the world, but if interpersonally there are problems, that's going to take away women's appropriate sexual response. Okay. So what are the sexual problems? What are the disorders according to the Diagnostic and Statistical Manual? That is the medical manual that all sexual disorders are sort of guided by and what physicians and mental health professionals use. So according to this, this document, the DSM-4-TR, there are 6 sexual disorders for women. Okay? They are listed as in sort of groups of 4, but they are hypoactive sexual desire disorder, sexual aversion disorder, arousal disorder, orgasmic disorder, dyspareunia, which is simply defined as pain with intercourse, and vaginismus, which is an anxiety response where despite wanted sexual penetration, intercourse, the vagina essentially tightens up in anticipation of pain. It is a very common disorder, actually, and one that prevents consummation of many, many marriages. I see probably 5 a week of women who have waited years, and it's usually because now they're dealing with infertility and they want to have children that they finally come out of the closet, and it's a very distressing problem. Okay, so of all of those 6, let me just tell you, there's tremendous overlap. And this is complicated because now it's complicated for women coming in with a sexual problem, and it's complicated for the healthcare professional trying to figure out, well, what really is the primary problem and how do I address it? Because for women, sexual problems have tremendous overlap. And by what I mean is, say somebody comes in and really what they have is low desire. Okay? Biologically, they have no urge to be sexual, and that's causing them distress. But they walk in and their healthcare provider says, well, do you have any sexual concerns? And she says, yes, I have pain when I have intercourse. Well, really, the reason she has pain is because she had no desire, so therefore her body didn't get aroused, and without arousal, without lubrication, when she tried to have intercourse, it hurt. Okay? And so she's coming in with the symptom of pain when, in fact, the problem was desire. In contrast, another woman walks into her healthcare provider's office and he or she says, do you have any sexual concerns? And she says, yes, I don't want to have sex anymore. And so the healthcare provider says, oh, well, we have a desire disorder here. But in fact, if you did a little history, it turns out she doesn't want to have sex because every time she went to have sex, it hurt. And guess what? After a while, every time you have sex and it hurts, you don't want to have it anymore. And so we have a misdiagnosis here because, Here's a woman who really just probably needed, maybe she was postmenopausal, maybe she needed a little local estrogen cream for some vaginal atrophy, would have cured it, but in fact, she was misdiagnosed with desire disorder. So a lot of overlap. It is not hard to tease this out with a teeny bit of teaching and supporting the idea that, say, medical school nurse practitioners all need, 5 minutes of teaching to learn how to diagnose this, and some public teaching of women so that they don't go in blind. They understand how their bodies work and what problems they're having so that they can get adequate treatment. So we say, well, how big a problem is this? Is it 1%? Is it 2%? How many women really do have sexual problems? Well, it's actually more than you think. So if we look at this data, this is from the National Health and Social Life Survey. This study came out in the mid-90s. And this sort of is such a ubiquitous number that if you Google 43%, this study comes up. Because all of a sudden, we learned that almost 50% of women had some sexual complaints. So in this study of about 1,800 women, and they're relatively young, right, 18 to 59, 43% of women had complained of a sexual problem in the past 12 months, 31% of men. Okay? Now, if we fast forward to 2008, we have a different study. We have the Preside study. This was a study of 31,000 women, okay, between 18 and over 65. So all adult women, 31,000 women. And guess what? The number was exactly the same. It was 43% of women had reported having sexual problems, either with desire, arousal, or orgasm. And if we looked at how we would diagnose it as to an actual disorder, it was 10% that met the criteria for, in this case, hypoactive sexual desire disorder. Okay? So 1 in 10 met the criteria. 43% reported having a problem, 10% met the criteria for having a diagnosis. Okay? So when we think about this, let's break it down into the main problems of desire, arousal, and orgasm. If we break it down by age, here's the younger women, 18 to 44 years old. 9% had a desire disorder. Okay? 45 to 64, 12.3, and 65 and older, 7.4. And you say, well, does that make sense? Why would the oldest have less distress or less problems than the middle-aged and the younger? Well, think about it. The youngest, even the younger group, were almost at 10%. The middle-aged women were struggling the most because now with aging, they're having some more problems and they're distressed by it. The women who are 65 and older are thrilled that they're still sexual at all, and they are expecting that they're going to have problems, so they're a little less distressed by it. Their expectations are lower. It's not that they're not having problems, it's that their distress by it is a little less. They're sort of accepting a little bit more. So let me talk a little bit about what desire is, because this, as we go back for 1 second, we look at the prevalence rates. By far, hypoactive sexual desire disorder is the most prevalent sexual disorder, bar none, okay, across all women, across all ages. HSDD, it's a lousy term, so we shorten it to HSDD because it's hard to say. Hypoactive sexual desire disorder. It is the most prevalent, okay? So if we look at it, though, 3 components. Drive is the biologic piece, okay? That's the piece that says your body craves sexual disorder, it wants to be sexual. Your beliefs and expectations are the second piece, and motivation are all the interpersonal factors. That's what creates your interest in being sexual with a partner. Drive is the piece that we don't have anything on that is FDA approved for. Okay, I'm a good psychologist. I can treat the expectations, I can treat the motivation piece, but there is nothing FDA approved yet that works on the biologic piece. So when women come in and say, I have no desire, if I can get them in to talk about that, the fact is that I can treat the emotional parts and the psychological parts, but if there's a biologic component, there's nothing that I can offer them. Nothing yet. And if you say, well, so what? The fact is that having HSDD hurts self-esteem, can cause depression, and I'll end with this comment. When the impact on relationships is tremendous. When sex is good in a marriage, it's good. It adds some value, about 20% overall, okay? It adds some nice touches. But when sex is bad or non-existent, it plays an inordinately powerful role draining a marriage of goodwill. So, paradoxically, bad sex does way more to subvert a good relationship than good sex does to promote an average one. Okay? And with that, I thank you, and I hope you